Continuing education credits for physicians and other healthcare professionals are provided by VCU Healthcare Continuing Education. Check out cribsiders.vcuhealth.org for more information. The Cribsiders podcast is for entertainment, education, and informational purposes only. The views and statements expressed in this podcast are solely of those of the hosts.
Welcome back to the Cribsiders. I'm Sam Mazer, and I'm actually joined tonight with my co-host and producer for this episode, Crystal Nuara. Say hi, Crystal.
Hey.
So our guest tonight is Dr. Elena Galindo to discuss sexually transmitted infections. But first, Crystal, can you remind our audience about the show?
We are the Pediatric Medicine Podcast. We interview leading experts in the fields to bring clinical pearls, practice-changing knowledge, and answering lingering questions about core topics in pediatric medicine. We have a fantastic conversation with our guest, Dr. Galindo. She's an adolescent medicine physician at the Anthony L. Jordan Health Center in Rochester, New York. Dr. Galindo is passionate about health access, patient equity, and racial justice. Her clinical areas of interest are reproductive justice, sexual and reproductive health, including abortion care, gender care, and advocating for minority youth.
So, Crystal, let's swipe right on this conversation. Hi, Dr. Galindo. Thanks for coming on the show.
Hi, thank you for having me.
Of course. First, because we're in a little bit of an informal group, I'd like to ask, is it okay to call you by your first name?
Yes, it is.
Perfect. Well, Elena, we like to start with some rapid fire questions to get you know you a little bit better. So I was hoping you could give us a little bit of a one-liner to describe yourself, maybe like who you are, what you do, maybe something outside of medicine.
Okay. So I am a TikToker, a pediatrician. I am out of academic medicine. I work at an FQHC. I love Nutella and public markets all the time. And I am married to an engineer and I enjoy going to yoga.
Amazing. Yeah. And I love that you put Nutella up there too. As a physician, it's still okay to like heavily chocolated items. So shout out to everybody. Yes.
I also, I just go spoon to mouth. There's no,
right,
no intermediary.
Exactly. You know what you're doing is you're cutting down on the carbs. That's what you're doing. There's no need for bread.
Thank you.
No, straight to free.
Yeah, it's about efficiency, okay?
Yes.
There we go. And sometimes when we're not so efficient, maybe we have failures. So I'd love to ask you, what is your favorite failure?
So I did not realize until I was a third-year peds resident that pneumonia doesn't, in fact, have aspirations. It's just aspiration pneumonia, not aspirational pneumonia.
Ah, yes.
Like I had been calling it for 3 years until someone laughed at me at morning sign out, because of course I was on nights. And I'm like, why is everyone laughing? And they're like, aspirational? And I was like, well, my pneumonia likes to go places. Okay, guys, it has goals.
It aspires to be consolidation, all these things.
Thank you. So yes, that I will never forget that it's aspiration.
And always a good way to remember it too. And I actually think it is aspirational in many ways. So thank you for thank you actually for educating me on that component. I actually appreciate that.
Anytime.
Crystal, you want to actually jump into the case because we actually have a lot to talk about, and I want to make sure that we have enough time to do so.
Fall always feels like a reset. Between busier schedules and shorter days, finding the time to cook can be really tough. That's why I use Factor. Factor makes it easy to eat well without the stress of meal prep. Their meals are chef-prepared, dietitian approved, and ready in just 2 minutes. For me, that's huge. I often don't have much time in the hospital, and Factor lets me skip the chopping, cooking, and cleanup while still eating something satisfying. I also love their vegetarian meals, especially the pastas. They're comforting, filling, honestly some of my go-tos when I need something fast but delicious. Factor also gives you more variety each week, from Mediterranean diet meals to GLP-1 friendly options and even premium seafood like salmon and shrimp at no extra cost. And now you can try new bold global flavors too. No matter your routine, you'll find something that works. And with Factor, you can save time, eat well, and actually look forward to your meals, even on the busiest days. So here's the deal. Eat smart at factormeals.com/Cribsiders50off and use code Cribsiders50off to get 50% off your first box, plus free breakfast for 1 year. That's code Cribsiders50off at factormeals.com for 50% off your first box, plus free breakfast for 1 year. Get delicious, ready-to-eat meals delivered with Factor. Offer only valid for new Factor customers with code and qualifying auto-renewing subscription purchase.
Absolutely, I'd love to. So we are in the clinic. You are seeing Lydia, a 17-year-old assigned female at birth adolescent who's presenting for a problem visit. She's in the clinic alone and she wants to talk to you about testing for sexually transmitted infections. She's been sexually active with 2 male partners and 1 female partner over the past 2 years. She's never been tested before, but was encouraged by a friend to get checked out. So to start off our conversation, why is it important to talk about teens and sexually transmitted infections?
So like the short and sweet is because we don't always know if we have a sexually transmitted infection. Like there's not always symptoms that come with the infection. And so whenever I talk to my teens about maybe they've never had testing before, maybe this is the first time, maybe they had it like once in the past and they thought they were good, the one thing that I always lead with is that having sex is normal, but I want you to be doing it safely. And the way that we do it safely, an aspect of that is to be tested because you don't always know if you have an infection or not. You don't always show symptoms.
So, as we talk to these adolescents, I actually wanted to talk early in our episode because we usually do this with pretty much all of our episodes to talk a little bit about disparities. And so I did want to bring this up early and talk about, are there any disparities for people who are at risk for STIs? And then we can kind of continue on to talk about these patients.
I'm really happy that you brought this question up. So just even the structure of the question, that we know that Lydia is having sex with both male and female partners, I think really calls out the importance of asking our patients the genders of their partners instead of asking their sexual orientation. So like, are you straight? Are you gay? And then pigeonholing our patients into only having one type of sex. Because one of the disparities is like, if I have a patient that say they're only having sex with female identifying people, but then they sometimes have sex with people who were assigned male at birth, the risk profile is different. And so that's why I really wanted to highlight the importance of asking what are the genders of your partners, as that can be a disparity that we're not treating all of the possible risks or testing for all of the possible risks for our patients. The more classic disparities that we hear about and we read about, it particularly in studies, will highlight that my Black and brown youth are at higher risk of having STIs, when really I think it's more of a reflection of just structured racism in our educational system, but also it manifests in also where we're living, our access to healthcare, access to education, access to accurate information. And so I think that it can really break down in terms of that kind of thing. The other things that we like to think about are if what are the access to when thinking about access to education for my patients. And so I like to think of when my patients come into the clinic, I want to provide them with accurate information because we all know that my teens are going to then go and talk amongst each other. And I want the information at the lunch table to be accurate so that they can share it amongst everybody else.
Absolutely. And what I really appreciate about the way you spoke about that is I think a lot of people hear about the disparities in STIs and then are quick to then assign blame or have some type of judgment against our patients without recognizing that it's really a reflection of kind of the environment that they're in. And so it's great that patients like Lydia are taking the initiative to come into clinic and really take care of their health. And so to bring us back to our case, one of the things that I think it's important to differentiate is between screening and testing. And so if maybe you could talk a little bit about the difference between those two and what might be a routine screen for Lydia.
So I think of screening as my patient is just curious. Like I'm just curious about like, do I have any STIs? They're not showing any symptoms. They're not showing any symptoms, so they're just curious. I think of that as screening. Testing, on the other hand, is like my patient comes in and they've had if they're assigned female at birth, they've had change in their vaginal discharge because it is normal to have vaginal discharge, but the change in that discharge is usually when we get concerned. And is there a change in the amount, the type of discharge, the appearance of the discharge? If my patients are assigned male at birth, they're just having discharge in general, or any type of itching or lesions have presented. That goes for females as well. So that would be more of like testing, like I am looking for an answer to explain what is going on.
And as far as like a routine screening goes, for example, let's talk with Lydia right now, has no symptoms. We might change the case shortly, but let's say she has no symptoms. So what would be a routine screen for her? And when would you do those as well?
Yeah. So per AAP guidelines, women or assigned female at birth under the age of 25 are supposed to have a yearly screening for gonorrhea and chlamydia. And then for all teens, they're supposed to have a screening for HIV at least once between the ages of 16 to 18.
Awesome. So we're talking HIV, we're talking gonorrhea, we're talking chlamydia. And I'm going to also ask you the follow-up question here, which is how do you actually obtain those tests? Because I know there's difference in sensitivity and specificity about where you do it and that type of thing. So if you wouldn't mind being able to kind of walk us through how we screen for those.
Yeah. So when it comes to gonorrhea and chlamydia, I make it very clear to my patients that those tests come from a swab. For just screening, I usually just get, if they're assigned female at birth, vaginal swab or frontal hole swab. If they're assigned male at birth, you can get it from urine, and that is just for screening. And then for HIV screening, I make it very clear to my patients that those are a blood test. And that is just, I send them to the lab and they get a poke. And the reason that I emphasize like swab testing versus blood testing is because very often I will have patients come in and they will tell me that, oh, I got STI testing at a different location. And I'm like, okay, cool. What did you get tested for? And they're like, well, I don't know. I got everything. And it's very frequent and it's really sad, but my patients never really know what they get tested for, which definitely goes to disparities. And so I break it down. I'm like, well, did you have blood testing or did you just like pee in a cup or did you have swab testing as well? And usually that kind of helps trigger in their minds like, oh, I didn't get any blood testing. So I know they didn't get HIV or syphilis testing.
And actually, let me ask this question first, just because you mentioned HIV and now you mentioned syphilis. Does any local setting influence what you're screening for? Because you mentioned AAP guidelines are gonorrhea, chlamydia, HIV. When do you test for syphilis, for example? When do you test for anything else? Does anything change that?
So right now I'm in New York. I was previously in Los Angeles. And between those two sites, I feel like I have heard amongst like general talking that there is that syphilis is on the rise. And so whenever I am screening for HIV, since I'm already poking them, I always tack on syphilis. And that's just like my own personal practice, I guess you would say.
Yeah.
And I think one area that maybe we can talk a little bit more about is the site testing, since we're right here, is the difference between when you would recommend a urine versus a vaginal swab for a person who's assigned female at birth. Any differences in that? And then maybe some practices around rectal screening and oral screening as well too, or oral site testing and rectal site testing.
So my personal practice is to always just do frontal hole swabs whenever I am considering during urine testing. Instead, I do swab testing I think it is more accurate. I would have to look it up. But that's definitely just like my personal practice is to do swabbing of any site that is involved in sex. And so I always am careful to ask my patients what types of sex are they having, oral, vaginal, anal, and then I swab any site that is involved. And if I'm doing a pelvic exam, whether that is usually for like an IUD placement, I go ahead and I get cervical swabs since I'm there. But usually I have patients do self swabs, and I instruct them on how to do it. Or there's like picture diagrams in the clinic. And then you asked about rectal testing. So if they're having anal sex, I definitely get anal swabs as well.
And just before we kind of move on the rest of the case, I wanted to just wrap up with one final thing about routine screening. Do you recommend routine screening for every single one of these kids, regardless if they're having sex, or do you need to hear from them to tell you that they are actively having sex to then choose to do this?
This has been something that I've been wrestling with in my own practice. I definitely make an effort to talk to all of my teens about safe sex so that they have heard these things before. I have normalized getting testing. I normalize what we test for, and normalize talking about sex, and also like talking about pleasure if they are having sex. I have not had really great success at getting my non-sexually active patients to get tested. And so I'm really, autonomy is very close to my heart, and also reproductive justice is very close to my heart, and definitely part of my practice. And so if I trust my patients when they tell me that they're not having sex, and so I don't really push the issue, but I definitely let them know, if you were having sex, these are the reasons why you would want to get tested. These are the things I would be looking for. And this is why I would be having this conversation with you, testing for these things of that sort.
And, this kind of brings us into something that we'll probably get later in the show, but I still want to ask it now. You talked about how you're going to ask and talk to these kids about it. I would love if you could just kind of start talking about that with us and share kind of how you have that conversation to begin with. And then we'll go back to the case. I'm sorry to delay that, but I really want to kind of hear how you have this conversation.
Yeah, no worries. So I definitely, unless it is a rare scenario, I always have the parents step out of the room. And usually the way that I bring it up with parents is, your child is at an age where it is good for them to start getting used to advocating for themselves in terms of what is important, what health concerns are important for them. Would you mind stepping out and give us about 5-10 minutes to speak privately? The parents are usually like out of the room before I have finished even finishing my spiel. Whenever I am with the patient, and we have privacy, I always let them know that what they say here stays here, and that this time is what's known as confidential, meaning that I don't tell your parents anything that we discuss, unless you are mentioning thoughts or feelings that you would be better off dead, or that you would like to harm other people. And in order to keep you safe and keep other people safe, I would then need to get your parents involved. And the teens are usually very understanding about that. But then I also tell them that if they are having those thoughts and feelings, that those are very important and I want to know. And they're like, okay. I usually then kind of go through my HEDS assessment and start with the less sensitive topics first. But if my patient has questions about sex right off the bat, then we jump right into it. But whenever I get towards like the part of the HEDS assessment that's talking about sex, I ask them, is it okay that I have some sensitive questions? And they're like, yeah, sure. And usually they're pretty eager to hear more about it. And so I ask them, are you sexually active, or have you heard about sex? I tailor it to where they are developmentally. So like my very precious 12 and 13-year-olds, like 14-year-olds, I usually start talking about like, do they have crushes on anybody? Have they had their first kiss yet? Have they heard about sex? As opposed to like, are they sexually active? I usually reserve that question for my more like 15, 16 and older patients. And where do I go from there? I usually, I really just kind of follow like what the patient takes me. And so like if they haven't heard about sex, then of course we talk about it. I definitely talk about condom use in my clinic. I actually have like a penis that I use to show how to put on a condom. I also have like a model, like it's the old vaginal ring models that they used to hand out. I have hoarded it to my desk because I love the anatomy of it, that I can show like just all of like the female pelvic anatomy. That is always such a mystery to patients. And then one of the things that I am definitely incorporating into my personal practice a lot more is normalizing the aspect of pleasure, particularly for people assigned female at birth, and talking about it and asking my patients like who are sexually active, like, do you feel pleasure from your sex life? And asking them like, do you have questions about that? And that usually then leads to a conversation about foreplay and lube, and how lube is very necessary if whether you're using sex toys or if your partner has a penis, and how important that is. And usually I am the only person that has ever talked to them about pleasure. And so I'm hoping to get more of my colleagues to talk to their patients about that and the importance of it. The other things that I definitely mention, both like with parents in the room, either when I'm doing a genital exam, particularly for like my like very early pubescent children or patients, and then definitely when I'm in the room privately with patients and we're talking about sex, or like thinking about having sex, is the aspect of inappropriate touching, and how like if they don't want me to perform an exam, then, and I don't really need to perform an exam, then I'm not going to. If I need to perform an exam, I usually then have a much more extensive conversation with them. And if they still are like, absolutely not, then I tell them what I would be looking for. Because at all costs, I want to try my best at honoring their autonomy. So I kind of work a lot of things in it, if I have the time, into that conversation.
That's perfect. I think it kind of goes over the basics of taking a really comprehensive sexual history. So transitioning back to our case, Lydia shares that she's had some vaginal discharge, burning sensation for 3 days. Does this change your workup and what you're doing for Lydia in the clinic?
So for Lydia, I would counsel her on the importance of getting gonorrhea, chlamydia, trichomonas testing, and also a vaginitis screen. So I would screen for yeast infection and bacterial vaginosis.
Awesome. And then in this case, you had mentioned about self-swabbing when you were doing routine screening. Was this a case where you would do self-swabbing, or would you do this exam yourself and do a swab because you are now concerned that you're going to get an appropriate sample, for example?
That's a good question. My go-to is for them to do self-swab. If this was like their very first time and they are significantly concerned, they just want reassurance that everything either looks normal or there's nothing else going on down there, then I will happily do a pelvic exam, and then I would just obtain the swabs myself. If this is so Lydia has already been having sex, maybe she's already been tested, I don't know. Then I would allow her to do self-swab, especially if she says, oh yeah, I feel comfortable doing it, like that's fine. I have noticed that a lot of my patients, maybe not a lot, I have noticed that a good number of my patients don't feel comfortable actually touching their own vulva or their own vagina. And so the idea of self-swab to them is like, no, thank you. So that would be another instance when I would do a pelvic exam and just obtain the sample myself.
And just out of curiosity, is there anything that you're going to see on exam that will change your management in these moments? Because it sounds like, look, we're going to test for these 5 disease processes with a PCR test, no matter what. I'm curious, is there something that if you do a pelvic exam, you see something like, what would you even be looking for that would be different? Or, I actually don't know. That's what I'm asking.
If I were to see a lot of my patients shave their pubic hairs, you don't have to shave your pubic hair, by the way. But with that, they will oftentimes have like a folliculitis that then I would, of course, see if I were doing the exam. And so that kind of gives me room to plug that you don't need to shave your pubic hair. Pubic hair is very important. But also you need to change your razor a lot more often. If they had any type of, speaking about Lydia in particular, if they had, and they were assigned female at birth, if they had like vaginal ulcers that were either going unnoticed, if they had different, I've never seen this before, but really large lymph nodes, like in their inguinal canal, that would of course change my management and my testing. But yeah, I think that's about it. Not much would change. There's not much on the exam that would change my management or the testing that I would order.
Because we're trying to talk about what's the indication to do an exam versus not. We did have a whole episode on pelvic inflammatory disease and PID, and obviously doing part of an exam there is for looking for cervical motion tenderness or adnexal tenderness of any of the sort. And so we're just curious about, when do you find that you need to do a pelvic exam versus just kind of swab them off the bat? And it sounds like for the majority of patients, we could just swab them off the bat. But where do you kind of draw that line when you talk to them?
Yeah. Oh, PID is so serious. And I'm really happy you guys had a podcast about that one.
Yeah, check it out.
I will. So if I had a patient, and this is just in the outpatient setting. So if I had a patient that told me, like if Lydia was telling me that for 3 to 5 days, she's been having this awful belly pain. Her pelvis she's been having belly pain, pelvic pain. Walking has been difficult, substantial change in her vaginal discharge, pain in within her vagina area. If she had more symptoms than just vaginal, change in vaginal discharge, plus minus a fever, I would almost just preemptively treat for PID. I would attempt an exam, but also I wouldn't die on that hill because I know that I'm going to just preemptively treat for PID in that situation. And that definitely comes with counseling around the importance of treating PID, particularly around fertility.
Yeah.
That I feel like sometimes isn't necessarily mentioned when we're talking about PID.
And I think that was actually a big takeaway from Dr. Wood's talk with us at the time, which was, look, when you talk about risk benefit and risk tolerance, infertility, huge problem. Treating for PID, we have a very, very low risk tolerance when it comes to that. And so therefore, we go ahead and treat empirically a lot of times. But I want to point everyone to that episode, and we can learn more about that there. But Crystal, you had a question before we move on.
Yeah, it sounds like what's also really key here is going back and making sure that you're getting a really good history. And is there anything that you are listening on history that's going to help you determine if this is vaginosis versus, or bacterial vaginosis versus yeast versus STI, based on just medical history alone?
If it's recurrent, I oftentimes think about BV or yeast. We're getting into the summer months, so have they been hanging out in a bathing suit too long? I think about yeast. If they, every time they have sex and they get this change in their vaginal discharge and itching, and it's just general discomfort in their vagina, I'm thinking more bacterial vaginosis. Or if it's I haven't really had sex recent, or it's been a while since I've had sex, it is just itching and I have this white discharge, and then I'm definitely thinking more yeast.
Perfect. I think that's really helpful. Kind of. I remember like studying those tables and like, just getting ready for step one and making sure I knew all of the key words there. And so I think hearing that in the clinical context and how you're actually using that in practice is helpful. So let's say you send off the test for Lydia and they come back the next day positive for chlamydia. What are your best practices with sharing test results with adolescents?
I think the biggest, most humongous takeaway from this is privacy, and that, at least in the state of New York, adolescents are like, it is a legal obligation to provide them privacy around like sexual and reproductive health. They can consent to their own treatment. They can consent to their own testing. And so definitely honoring that privacy. And so the best way that I have found to do that is to always get their cell phone number or an email address or both, so that you can call with the results of their labs. And also then letting them know, like, hey, I am going to call you with your lab results. So that they know to answer the phone, because sometimes they'll ignore your phone call if they don't know the number. But that is definitely, like, I've had to learn that the hard way a couple of times, and it's not fun.
Do you feel like you can never get ahead of charting? Imagine a world where you don't need to think about notes again. Introducing Freed, an AI medical scribe built to free clinicians everywhere. It listens, transcribes, and writes instant clinical notes for you in your style. Freed can be used across all specialties for in-office as well as virtual visits, and it works in multiple languages. Written in your style and ready the moment the visit is over, all you have to do is copy it into your EHR. Freed is HIPAA compliant and only takes seconds to learn. Over 15,000 clinicians, including doctors, APPs, therapists, use Freed to save up to 2 hours every day and free themselves from that documentation. Just imagine the great feeling of coming home without any notes hanging over your head. Get back to doing what you love and let Freed do the rest. And start your free trial today, no credit card needed. Use code CURB50 to get $50 off your first month when you subscribe. That's code CURB50 to get $50 off your first month when you subscribe.
And, when it comes to sharing this, I was recently had this case where and granted, I'm a hospitalist, but a kid came in with concern for a secondary syphilis, and we were working this up, and I was so concerned about talking about how I was going to share this result with this child or this teen, and eventually did. And the irony is, he actually had no idea what syphilis was, like had not even a kind of a concept, despite us kind of talking about it. So I was actually wondering, you say, I'm working you up for a sexually transmitted infection, and you're going to call you back with that. But do you have some of these conversations, like what actually is chlamydia versus not? And how do those conversations go?
Whew, we're taking it all the way back. I definitely talk to my patients about like, what is a sexually transmitted infection? And sometimes they don't know what an STI is, but they know what an STD is. And so I'm like, tomato, tomato.
Yeah.
But I let them know, like, chlamydia is a bacteria, gonorrhea is a bacteria that is spread through sex. And so that means that if you are having oral sex, you can get an STI, you can get gonorrhea, you can get chlamydia that way. You can have gonorrhea, chlamydia of your anus, where, and then I remind them that's the hole where the poop comes out. And you can also get like gonorrhea, chlamydia of your vagina, which is the front hole. And usually they're like, oh, okay. But I let them know that the reason that we want to treat the infection early is to actually prevent PID. And because the bacteria can actually go up your vaginal canal. And this is really where my model, my pelvic model comes into play. And I'm able to show them, like, this is, because like I have the model, I'm like, this is your vagina. This is where like the penis would go inside. And as you can see, like, it is connected to your cervix. And so like the bacteria can climb up into the cervix, into your uterus, and it can infect everything that it comes into contact with. And usually with the visual, my patients are then able to really grasp and understand not just their own anatomy, but then like why we're worried about the infection.
And then they're like, uh-oh, can you prevent that? Can you make that better? Please help. How do you counsel them about treatment in those cases?
I let them know that we can definitely make this infection go away. And that is why testing is so important. And so I tell them that like of all of their STIs that are like the general ones, so like your gonorrhea, chlamydia, syphilis, HIV, and I even say bacterial vaginosis, all of them can be treated, and most of them can be cured except HIV. But then I let them know that even with HIV, you can, the medication has really substantially improved everyone's quality of life. And so, although it cannot be cured, you can get down to undetectable.
And from like a practical perspective, where are you recommending that teens get treatment, and what about their partners?
I believe partner treatment is state specific. And so I always encourage my patients to get tested in the clinic. That could sometimes mean they have a high school based clinic, which I really love when my patients have those because it really meets them where they're at. They can come back to me and get both testing and treatment. They can go to a Planned Parenthood where they can get testing and treatment as well. When it comes to their treatment, again, that's really why I emphasize having their cell phone and having direct communication to them to maintain their privacy, because they know themselves, they know their lives best, and how to navigate their life enough to either get to clinic where I can provide treatment or to get to a pharmacy where I can provide treatment as well. And how will we make that happen? When it comes to partner treatment, I am able to provide partner treatment in the state of New York because I'm legally allowed to do so, which I don't know if I was ever told in medical school that I would need to know the laws of the land. But having to learn those along the way has been very valuable and practice changing as to like, what can I do legally? And so being able to legally provide partner treatment is something that I also speak with my patients about, because it very often brings up the conversation or the thought of, I have to tell my partner that I have an STI. I have to then tell my partner that I have their medication. Like, how do I navigate this? How do I have that conversation? Like, it is very common that my patients become very avoidant, and they're like, no, I don't want to have that conversation. I'm not going to do that. I'm just going to tell them they need to go to the clinic. And I just work with my patients when it comes to partner treatment, because if they feel unsafe to have that conversation with their partner, I don't want to purposefully put them in a situation where they feel unsafe. If they feel that their privacy will not be honored, I don't want to like put them at risk of being in that situation as well. But if they feel comfortable with their partner, if they feel safe with them to have that conversation, I will say, well, let's practice having that conversation while we're here in the clinic. So let's like role play that conversation. And usually that lowers some amount of anxiety that they have. And so I will send their prescription to the pharmacy, and then I will like double it. And I will like make a note to the pharmacist that this is expedited partner treatment.
And I think what's really helpful there too is that counseling the adolescent around a positive result. And one of the things that I love working with teenagers and adolescents is that a lot of their emotions can be really big emotions and things and situations they're navigating for the first time. And so I was wondering if you could even talk a little bit more about emotions that come up with, is my partner cheating? Or what does it mean now that I have a positive test? What does this mean for the rest of my life? And some of the stigma that can come around having or being diagnosed with an STI.
This comes up a lot, particularly is my partner cheating. And I usually do not bring it up myself. I usually kind of wait about 60 to 120 seconds And then it will start to like click for my patient, and then they will bring it up themselves. And so I talked to them about it. I'm like, tell me, like, what are you feeling? Like, what are your thoughts around your partner? Because that inherently then brings up the aspect of trust. Like, can I trust my partner? And then that usually leads to the question of safety around my partner. Maybe not like intimate partner violence kind of safety, but like, can I trust this person to care about my own health? And is that something that like I want to move forward with? One of the things that's a little bit nuanced, though, it goes back to the knowledge that we don't always know if we have an STI. And so if it's a new relationship, this is their first time having sex, and now they're in the clinic, I will like kind of add that nuance of this may not have been an episode of cheating. This may be an STI from their previous partner. And so I will caution jumping to conclusions, but I will also then try and role model with the patient what having a vulnerable conversation looks like with their partner. So do you trust your partner enough to disclose that, hey, I went and got tested, you should too. But my test came back positive. Can we talk about this? Did you ever get testing previously? What were your last test results? And this is also where I reiterate to my patient the importance of always getting testing before and after partners, and also having the atmosphere or having the expectation in your relationship that you share your STI results as just as like a level of trust with each other, and it's also helps. It's also, to me, it's like if I can share my STI results with you, and I know that you are sincerely sharing your results with me, it also is a way to like bring you closer together as partners as well.
That's awesome. And, this sounds like it's not an easy conversation and not one size fits all either, but it sounds like this is a good way to start it. And at least there's some ideas for our listeners to kind of have with these teenagers. I did want to kind of jump a little bit more to the treatment. We kind of mentioned treatment and expedited partner treatment. We didn't actually talk about what treatment is. Can you kind of walk us through just kind of basic, let's just put it this way. We sent a 5 PCRs. We sent, Candida, bacterial vaginosis, trichomonas, gonorrhea, chlamydia. If we want to treat, say this time it came back with a positive PCR for chlamydia, but if it comes back for any of these things, what are our treatments for STIs in general?
Yeah. So starting with chlamydia, because I think this one was, there was a lot of fanfare around it recently because it changed. So it used to be, or at least the recommended treatment used to be a gram of azithromycin once and you were done. And it most recently changed to doxy 100 milligrams twice a day for 7 days. I will say that it really depends on the patient. If I know that my patient will come back, or I know that my patient has immediate access to a pharmacy, or they won't lose their pills, or their partner won't dump their pills in the middle of the street in a puddle, or like they can safely take their medicine every single day, I will give them the doxy. But if my patient is homeless, not staying in the same house all the time, they don't have immediate access to a clinic, or like they don't have a lot of buy-in into the importance of this treatment anyway, I have a very low threshold to give them a gram of azithromycin. And that is my personal practice.
And actually, before we go into the other treatments for the other pieces, I think this is a great transition just to talk about empiric treatment and who you would choose to empirically treat in your clinic. Hey, can I get in touch with you? Hey, are you going to come back? Do these same things apply with like, you're getting a dose of this and on the day of a day of presentation, or is there nuance somewhere in between?
Oh God, I feel like with adolescent medicine, there's always nuance.
True.
we live in the gray. There is no black and white. So really, honestly, it changes, and it is very nuanced, and it's very case dependent. So like if I have, and I hate using this term, but if I have a quote unquote high risk patient, then I am most likely going to preemptively treat for what I tested for. So I would give what kind of boils down to almost like PID treatment, but like a gram of azithromycin, probably like either 500 milligrams or a gram of ceftriaxone, because I can do both of these in the clinic. And then we think about metronidazole for bacterial vaginosis. And usually then like what I would do is I would call them with their results. And so if their BV is negative, I'm like, hey, you can stop the metronidazole. I remember doing, instead of azithromycin, we were doing doxy. And so we would call and say, hey, your chlamydia is negative, you can stop the doxy. But they already received the ceftriaxone. And so it's like, okay. If it's like a slam dunk for yeast, like if they're really having a bunch of itching, then like I would start them on fluconazole. But like if there's no itching and there's no substantial discharge, then like I wouldn't always start it. It's not my go-to to start, whereas like the other three, I'm like just passing it out.
But, just because we kind of mentioned this, started this conversation, then got a little bit sidetracked. So that was me. I apologize. But it sounds like doxycycline and or azithromycin. Honestly, doxycycline is the goal, but azithromycin based on, because the best medicine to give is the one that you take. And then ceftriaxone for gonorrhea, metronidazole for bacterial vaginosis / trichomonas, and then fluconazole for Candida. And I'll just shout this out for myself. I use the CDC app. STI app is my favorite app for all of these things right now, as of the time of this recording. And you can find all those answers there. Is there anything that I missed from a treatment standpoint that you would do differently other than the things I mentioned?
Hot new study that just came out, partner treatment for bacterial vaginosis. So like hoot. So definitely excited and enthusiastic about doing partner treatment for that.
And I will link to those updated studies in our show notes. And I'm sure our audience is excited to put that into practice. I know that's something that I'm excited about as well, too.
Oh, yes.
All right. So we are back in the clinic. We are with Phil. Phil is a 16-year-old assigned male at birth who presents for a well child visit. During the chaperone genital exam, you notice several cropped up vesicles on his genitals. And so I wanted to take us into a conversation around herpes and how do you test for herpes?
So the way that you test for herpes is you have to swab the lesion. So if the vesicle is already open, then you don't need to unroof it. You just swab what is there. If the vesicle is closed, you need to unroof the vesicle and swab the lesion. So the standard is to then send the swab for a culture. What seems to be the more sensitive and specific test is to actually send the swab for real-time PCR. The concern is that the real-time PCR test is more expensive than the culture. So it varies on what is available at your institution. I remember when I was in med school that like the slam dunk answer was a zinc smear. Per up to date, that is no longer in favor for anything, because apparently it is not helpful unless it is positive, I think.
Yeah, PCR is way better than anything these days, and so we should PCR everything. I am curious too, though, if you also, say you don't really know genital lesions, which is something that I don't know well, and I can't tell you that this is vesicular, this is multiple, this is whatever. Is it okay to also send the swab for chlamydia do the rest of our STI testing on that, or is that a relatively useless experience because it would be unrelated?
I think if you are swabbing a skin lesion, it will unfortunately be very useless to test for gonorrhea or chlamydia. You need a mucous membrane to test for gonorrhea or chlamydia.
Awesome.
So in that case, are you often co-testing then? So if someone has a vesicle, are you also recommending that they also get mucous membrane testing for the other sexually transmitted infections?
Oh, yes, most definitely.
And so let's say you are talking to Phil and you're thinking, you're like in your computer, you're ordering the test, and you also see the serum. And you're like, oh, maybe I can send off the serum. How are you thinking about serum tests for herpes?
So it would be so easy to send a blood test, but it is not good for herpes. It is a hard no on sending any blood testing for herpes if you are trying to make the diagnosis, especially if you have active lesions. It is the gold standard to send a swab for either a real-time PCR or a culture. I actually had to look this up, and I was on UpToDate, and the only instances that like you would send a blood test would be like if the patient at one time in the past told you that they had genital ulcers and they never had a swab at that time, or a culture or a PCR, then like you could send a blood test at that point. Or if they had a very atypical presentation for herpes, then you would be justified in sending the blood test. But in like the general thinking and approach to herpes is blood tests are a hard no when it comes to trying to make the diagnosis. You need to make a swab.
And Crystal, before you get to the results of our PCR, just a pro tip to actually unroof lesions. Usually the swab that comes with the viral medium is usually quite has a lot of rough coating to it, and you can use that to just kind of brush and move and unroof those swabs, because you can just rip open the top of the vesicle just with that brush and then twist it around, which I find very different than trying to figure out how I'm going to take a scalpel to someone's genitals. So would recommend that for those that haven't used it before.
That's an excellent pro tip, but I think one that I will definitely keep in my pocket for future patients that I see. So you send the test for herpes and other STIs after discussing it with Phil, and it comes back positive, and he is immediately emotional. Is there anything specific about the diagnosis of herpes that's particularly emotional for our adolescents and teenagers?
I think the hard part for teens to wrap their head around is that this is a lifelong illness. I would counsel my patients that they need to, whether they are assigned female at birth or male at birth, that they need to tell their partners that they have herpes and their risk of transmission during if they were to have sex. For Phil in particular, I would give him the space. I would give him space to emote, to have his big feelings. I try to make myself a safe person to process feelings with, and recognizing that this particular visit may not be the best time to have what could be life-changing counseling around how he then needs to conduct himself in his own sex life. How should he alert partners, both future and maybe present, maybe past, depending on when this was potentially contracted. And would really just try to validate what he's feeling.
I think what I'm really getting out of this conversation is that it's so tailored to the patient and giving our young people opportunities and space to think about what this means for them and how they can really take best care of themselves. And so how are you thinking about treatment for herpes for Phil?
So valacyclovir, 1,000 milligrams twice a day for 7 to 10 days has been shown to significantly reduce the duration and the severity of the illness by like days to weeks. And so I would not allow him to leave my office without that prescription. When it comes to the additional counseling around what does this mean? What does this mean for potential partners? And that related counseling, I would try, if my schedule allows it, to see him back either in a couple of days or a week, but I definitely wouldn't allow a lot of time to go by. I would then use that second appointment to conduct the counseling that I want to provide, but then also to check in to see how his symptoms are going now that he had been on the medication and the treatment.
I mean, I think this is a great opportunity to talk kind of about our final point here, which is protecting ourselves against STIs. How can we talk to our patients about both, for all of the different infections that we talked about? How can we talk to our teens about protecting themselves against that moving forward, moving into the future? What all of those type of conversations that you have.
This question I really appreciate because I think it's definitely one of the most important take home points that I would want as a learner, because this is usually more of the conversation that I have with my patients. So it depends on who my patients are having sex with, the genders of their partners. If their partners were assigned male at birth, and then I talk about condoms. If their partners were assigned female at birth, I talk about dental dams. And then I also talk about, for anybody having sex that are using sex toys, the importance of cleaning their sex toys, because you can still transmit STIs with dirty sex toys. I also talk a lot about PrEP, which I know could be an entire podcast all in of itself. But the way that I kind of keep it simple for my patients is I let them know, hey, did you know that there's a pill that can protect you from getting HIV? There's also a shot, but I really focus on the pills with them. And usually they're like, no, this is brand new information. And I'm like, yeah, it's called PrEP. And if you ever, when you start having sex, and you want to learn more about it, we can always talk more about PrEP. And they're like, oh, okay, cool. And then I also talk about DoxyPep, which is a way to protect you from chlamydia and syphilis, and usually gonorrhea as well, although the studies are not as strong at showing that it works against gonorrhea as consistently as it does against chlamydia and syphilis. And then one of the most important things that I'm surprised I have not mentioned so far is actually consent. I speak a lot about consent with my patients, and I start talking about consent from the time that I start having the parents step out of the room. And I let it be known that both partners need to be enthusiastically providing ongoing consent throughout the entire sexual encounter, and that if either partner expresses any hesitation, says straight up, no, I don't know, or there is any influence of other substances, then things are to stop immediately. And I focus on that with all of my patients. I'm not gender specific. It's all of my patients, because consent is definitely another way that we can protect ourselves.
And I actually think the word enthusiastic consent is very important, but that is a buzz term in academics and things like that. How do you explain to a 15 or 16-year-old or a 17-year-old what is enthusiastic consent? How do you even explain what that concept is? Because I feel like it's more of an academic concept in many ways.
I always encourage my teens to have a conversation about sex with their partner. Does your partner know what it is? Has your partner thought about it? Do they know what feels good with their body? That's usually my older patients. And what are their thoughts about having sex with you? What are your thoughts on having sex with them? And then kind of going from there. So if your partner is saying, yes, I want to have sex, let's do it. Or they're using any type of language that, is communicating that all things are a go, that is enthusiastic, that they are in it, they are engaged, they they're not hesitant, they're not kind of standoffish or pulling away or having questions, then that is that's kind of how I explain that.
Awesome. So we talked about, barrier protection, condoms, and dental dams. We talked about PEP. We talked about in PrEP when we talked about DoxyPEP. And we will definitely do direct episodes on these things in order to really dive into how we prescribe and how you what pills you are physically giving them, and what lab monitors things later on. If that is kind of all the pieces there, we would love to kind of get to some take-home points. We've used up so much of your time already. You mentioned a big take-home point being enthusiastic consent, so I'm glad we talked about it. Are there any other take-home points that you have for our listeners?
Oh, so many. Everyone should do an adolescent medicine fellowship. Like, duh, it's the greatest. But consent, asking the genders of your patients, asking the type of sex that they're having, and I think talking to them about ways to protect themselves is like you will touch more patients than you know, because I feel like it is those topics that either people don't think about, they're too hesitant to ask, they're afraid to ask or even bring it up. I promise you, you're not going to have everyone going out and having sex just by asking them if they've ever had sex before. Because our patients come to us as leaders in our community, and they come to us seeking authentic and correct information. And it's sometimes very hard for them to get this from their parents or other trusted adults. And we are in a position of privilege where we can be that trusted adult. And so it's actually really important for us to utilize that privilege to talk about the things that are very difficult to talk about.
Awesome. And is there anything you'd like to plug? Any websites we should go to? This is something that I know there's a lot of advocacy for. Is there anything that we should send our listeners to?
So I have to plug my Instagram and TikTok page. It's Radical Teen Medicine. And I am finally getting it back up and started again. I was very active, but then things got very busy in my life. And so I am getting restarted again. But I talk a lot about sexual and reproductive health topics on that. And it's definitely geared towards patients on that page. I would be nothing without Up to Date. I use it with every patient. And I also use the CDC guidelines for now. Hopefully it stays great. And also, going beyond those things, I also lean a lot on my reproductive justice resources, such as Sister Song. And so I use the reproductive justice framework and ethos to guide all of my counseling that I have for patients. So I would really encourage all providers to really become stewards of reproductive justice and take that approach with all of our patients. For those that don't know what reproductive justice is, just very quickly, it is the right to have children, to not have children, and to parent those children in a safe and healthy environment. And it's also the right to bodily autonomy. But when I was a peds resident and also as an adolescent medicine fellow, being not the attending, but the fellow on the team of pediatric residents, the way that I frame and reproductive justice and make it relevant to my pediatricians is that we're in a position where we can immediately impact the safety and the environment of our children and our patients. And so our families have the right to parent their children in a safe and healthy environment. And that is where we can immediately impact the health part and the safety part. And so really all aspects of reproductive justice apply to both general pediatrics, adolescent medicine, family medicine, internal medicine, anybody.
Awesome. Well, thank you so much for your time. We really appreciate you coming on the show. And we'll definitely send all our listeners to those places. So thank you again.
Why, thank you. Thank you for your time. I appreciate this opportunity.
The number you have dialed has been changed. The new number is...
This has been another episode of the Cribsiders.
It's for the kids.
Get show notes and sign up for our bi-weekly Knowledge Food Formula Feeds newsletter on our website, www.thecribsiders.com.
We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts, or contact us at thecribsiders@gmail.com. Special thanks to our producer for this episode, Dr. Crystal Nawara, and our wonderful social media team, which is mostly Dr. Deni's crews on X, Blue Sky, and Instagram. I've been Sam Mazer.
And I've been Crystal Nora. Thank you and good night.